Hey, Vet Rehabbers, thanks for joining us. Hey, Steve, how you doing?
Yeah, very well, thanks, Megan. I hope you are as well.
It's awesome to have you on the Facebook Live. To all the Vet Rehabbers that are joining us live, thank you so much. If you guys have any questions, please pop them in the comments. If you're watching this as a recording, you can also pop the questions in the comments. So Steve is a veterinary surgeon and he is based here in South Africa, but I'm on the other side of the country in a place called Westville at Westville Veterinary Hospital. Steve, do you want to tell the people that are on live a little bit about yourself?
Yeah, sure. I'm in the older section of the graduates of veterinary science in South Africa now. I qualified in 1986, so in the last century, which sounds awful to my kids. I've been at Westville Veterinary Hospital since 1988, so 33 years. My main interests have been surgery all that time. I've developed my skills in all surgery, soft tissue and orthopedic, but mostly now I concentrate on orthopedic. And really knees have been my thing. From the moment I first dissected a knee in a dog way back in 1981 in Anatomy 1 and opened the knee, and I thought, this is cool. And I really found the whole structure of the knee and how it works fascinating. And and that's really been I've done 33 years of trying to help dogs with bad knees, and been through a lot of different techniques and procedures and surgery and conservative and rehab, and learned a lot, and I hope to share some of that with you today. I think, one of the biggest light bulb moments for me in the last 7 years, or paradigm shift, has been that not all cruciate ruptures need surgery. We can actually rehab many of them without surgery. And that's coming from a surgeon.
You and I have had a few conversations about this, and I recall the very first one was in 2017, which was episode 2 of the Veterinary Rehabilitation Podcast, which is absolutely amazing because I think I've got 160 now, something. And we chatted about prolotherapy. So I'm so excited to have you online today to chat about, the progress that you've made since 2017. So before we start chatting about prolotherapy, I want to ask you a question. So at our Vet Rehab Summit this year, it's on the 13th of November for all of those of you that are interested. It is our online veterinary rehab conference. Our theme is when research meets reality. So we are asking all the vet surgeons and all the vet rehabbers that we get to chat to a really important question. So the question is, what is the research that has made the biggest impact on your practice and way of thinking?
Well, maybe not so much the impact on my practice, because I have like 12 other vets in the practice and they all have their own interests and quote their different articles. But for me personally, the one I probably quote the most is the one I shared with you a few weeks ago, which is contralateral cruciate survival in dogs with unilateral non-contact cranial cruciate rupture. It basically was a retrospective study to find out how many dogs, after they've ruptured one cruciate, will go on and do the second one. And their stats were very interesting, and it was basically 54% of dogs that will rupture one cruciate will rupture the other in about a 1 to 3 year down the line from the first one. So that's very much what I use now to quote. I say, these poor people come in with their limping dog and it's a cruciate, and I'll say, well, start saving, because 54% of them that have done one are going to do the other, and they need to expect it. But following on from that, what's been hugely exciting for me is, and it was just another light bulb moment, is once I started doing prolotherapy for damaged cruciates or ruptured cruciates, I just thought to myself, the same process is going on in the other knee. Let me do what we might call a prophylactic prolo at the same time on the so-called good knee, and it doesn't really impact on the animals at all. I don't charge the owners anything extra for it. It doesn't seem to harm them in any way. But when I look back on the stats, recently I went back on all the prolos I've treated. So it was 210 normal knees, non-ruptured knees, the contralateral normal knee. I've done 210 normal knees, and up to date, only 15%, 1/5, have gone on to rupture that I know about. Some may have gone elsewhere. Some people may have moved away, immigrated, whatever. But that seems a lot better than 54%, even if there's some that have gone that I don't know about. So that's been really encouraging for me to carry on doing that. It does seem to help prevent the other side from going as well.
And this is something that you do when you're doing prolotherapy on the affected side as well as surgery. Is that right? So if you operate,
yeah, exactly. So if I'm going to surgery, then I'll do prolo at the same time as surgery on the good knee. Yeah. Normal knee. So
before I carry on asking you questions about prolotherapy, for those people that don't actually know what it is, could you just describe the procedure and exactly what we're trying to achieve by doing it?
Okay. The biggest take-home message about prolotherapy is one line that I explain to my owners, and it's a simple line: we heal by inflammation. And that was such a brilliant take-home message I got out of a rehab course given by Dr. Lowry from the UK 2 years ago. We heal by inflammation. So when we twist our ankle and the ankle swells up huge and painful, we actually shouldn't take anti-inflammatories. We can take painkillers, but not anti-inflammatories, because that inflammation is what triggers fibroblast activity and collagen deposition. So if we want ligaments to heal, we should not turn off inflammation. And what we're doing with prolotherapy is we're creating inflammation. We're stimulating fibroblast activity and collagen deposition in damaged ligaments and tendons around the body. So the body will be trying to heal itself, and we're just helping it by just creating more inflammation temporarily. So we use an irritant, most commonly around the world, the vets use dextrose, 25%, which is rapidly absorbed and non-harmful, but it does cause localized inflammation into the area you inject it. And that's what causes inflammation and then stimulates healing. And that's the take-home message for me about how prolotherapy works or why it works.
Are there any other things that you've tried to inject or that other people inject? I mean, I know that sometimes people will add Traumeal. Yeah,
I started by adding Traumeal. I was a little bit conflicted about that because my understanding of Traumeal is that it takes down swelling and bruising, and it's kind of opposite of what I actually wanted to achieve. I wasn't quite sure of the mechanism of action of it. Even when I read the pamphlet, it wasn't that clear. And I just thought I'm going to leave that out because I want to see what happens if I just keep it really simple, dextrose and lignocaine, and see what results I get. And they've been fantastic. So I started off with Traumeal, but I leave it out now.
Okay. And anything else you inject? Is it just those two?
No, it's just that, yeah. There are other products. I can't remember the names of, in the early days when I was reading about prolotherapy, there were other products that vets were using. But to me, the dextrose is easily available. It's non-harmful, and it's the one I started with, and at this stage I have no reason to change.
Yeah. So you'll basically sedate the patient, you shave the area and prep it as if you're doing surgery. And I've seen a video of yours, and we'll try and share that in on the Online Pet Health page on the Small Animal Vet Rehabs group. It's pretty hectic. Like, I see you with the needle sort of going into the tissue. But you basically shave the area, and then, in a syringe, you have the solution. And then you sort of like, correct me if I'm wrong, are sort of like pecking sort of on the bone where the attachment of the ligaments is. Is that right?
So, yeah, there's kind of two kinds of prolotherapy. There's a very precise, more gentle injection. If you're targeting a specific ligament, like a collateral ligament on a joint that's gone, and your landmarks, and then that you will use a 27 gauge needle, and you will not be very rough, and you'll inject that ligament all the way along its length a few times, and you'll create inflammation, very localized. And then when it comes to cruciates, I've changed that just out of my own kind of instinct and understanding of what I'm trying to achieve. So when it comes to cruciate repairs, you can't inject the damaged ligament. It's inside the joint, and it's broken and gone, and you're never going to get it to heal. So the way cruciates heal themselves, or the dog heals it, is by reducing instability. You want to reduce that anterior thrust, the tibial thrust or the drawer sign, by strengthening quadriceps muscles. So rehab is important, and then creating fibrosis around the joint, periarticular fibrosis. And there's two ways to create periarticular fibrosis. One is with surgery, especially X-cap surgery, and two is with prolotherapy. But now I want to create quite a lot of fibrosis when I'm doing prolotherapy periarticular in the stifle. So I'm actually quite rough. It is quite sore, and I do warn the owners, and the dogs are quite sore for a day or two. But it's really no pain, no gain. And I'll be pretty rough and create quite a lot of inflammation laterally and medially in the stifle joint. So medially over the collateral ligament where you feel the medial buttressing, and laterally along the same line as if I was going to put a nylon band in from the fibula to the tibia. Backwards and forwards along that line, creating fibrous tissue all the way along there, which then contributes to the stability of the knee when the dog is weight bearing. What's interesting though, we feel these knees when they're non-weight bearing, either in the wake state or when they're sedated, and we can palpate quite a marked drawer often. That's not what's happening in the knee when the dog is weight bearing. When the dog is weight bearing and the quadriceps and other supporting muscles and ligaments are actually contracting, that drawer is likely to be a lot less. So what I found with prolotherapy is we may not eliminate the anterior drawer or the cranial drawer or the thrust as much as we would do with surgery, but we eliminate it enough so that when the animal weight bears, the stifle feels stable and they can have a functional limb.
So sometimes you can still feel that cranial jaw, but then clinically you can actually see the improvements.
Exactly.
So what is the protocol? So you will inject them, so you sedate them and inject them. When is the next treatment that you'll do?
You can basically, if you read all the different vets out there doing prolo, it varies from 2 weeks to 6 weeks. I just thumbsucked 4 weeks and started with 4 weeks, and at this stage I don't really have a reason to change that protocol. So I tend to do the first treatment, send them off for rehab, weekly rehab, and then get them back every 4 weeks. And we generally, for knees, I'm talking specifically now because that's the most common prolotherapy I do. For knees, we tend to do 3 treatments and then assess where we are. Most dogs, if they're going to heal, they will be already doing really well at 12 weeks post-prolo, back to almost normal function by then.
And when you start seeing improvements like in their lameness, I mean, have you very quickly
It varies tremendously, and you can get quite depressed and think, oh, it's never going to work, and not going to work on this dog. So the response can be as soon as 1 week post the first prolotherapy to as late as 10 weeks after the third 2 weeks after the third prolotherapy, which would be 10 weeks down the line. And then it's also often not a straight upward curve to healing. It's often a very jagged up and down curve to healing, because the dogs are at home and they run around and they still chase things, the monkeys and the postman, and they aggravate it, and then they limp for a few days and then they settle down. But the degree of aggravation gets less over time, and the time they're limping for after an aggravation also gets less over time. So it eventually, by the 12-week mark, they usually sound.
Yeah. And you obviously are very pro rehab, so your prolotherapy cases have rehab during this whole period.
Absolutely. I get lots of them right without rehab, mostly because the owners just haven't got the time to do it, or financially just don't want to pay for rehab as well as prolo. But I strongly, every single Cruciate case or prolo case that I do, I give the handout of my 2 rehabilitationists that I work closely with, and I say, please, this is so beneficial to encouraging healing on top of what I'm doing. And I really urge them to do it. And I must say, most people are really good. I would say 7 out of 10 follow through with the physio. Awesome.
We've got quite a few people on live. Thanks, guys, for joining us. Please pop in the comments. Let us know where you're from. Say hi to us. It's lonely here. We're behind the computer screen, so it's nice for us to see where you're from. And say hello. We've got some great questions, Steve. So I've got a question which I'm going to pop up onto the screen. What about the development of osteoarthritis down the line on these prolo stifles?
Yeah, that's a fantastic question, and it's something that worried me in the beginning when I started doing it 7 years ago. So what I can tell you with confidence now, 7 years down the line, is that it's absolutely no less than X-cap surgery. In fact, some knees are even better than if I'd done surgery on them. It's amazing and surprising. So quite a few of these dogs I'm seeing down the line for other things, skins or vacs or routine checkups, and I'll just say to the owner, let me quickly take an x-ray at my charge. I just want to see what's happening in that knee. And I'm blown away sometimes, absolutely blown away. There's no sign of DJD. There's not even, you wouldn't even know that knee had a cruciate rupture. You know, I asked them if they brought the right dog, because you know, you just wouldn't know. I even question if I even had the right diagnosis to start with, because that knee looks so good. And it's not just one or two; it's many now. So if I had to rate the degree of osteoarthritis or degenerative joint disease I'm seeing in these cruciates, the difference between prolo or ex-cap surgery, I'd say it's nothing, no difference at all. In fact, if I ever got around to actually rating it and grading it, I would say that ex-cap surgery probably has more chance of getting severe DJD going into the joint than if you don't go into the joint. You know, a lot of people worry about this severe osteoarthritis on X-rays and palpation in knees once they've done their cruciates. It's a big concern, but actually, you know, I live by the quote, you know, treat the dog, not the X-ray. So many of these dogs with terrible DJD on rads or moderate and a little bit of crepitation and stuff, well, they're functional. You know, they're not racing greyhounds. They home domestic pets, but they have good quality of life. They use their legs really well, and they really don't need treatment. So it's there on X-ray, but it's not always clinical.
I got another great question is, what are the risks associated with the treatment, especially with older dogs?
So the risks are much less than surgery, which is why I do a lot of older dogs with comorbidities. We don't need a GA. We do sedate because it is sore. I really wouldn't like to do Prolo on a non-sedated dog, but I just use butorphanol and Domitor and a little bit of Prope, and it's literally 10 minutes of sedation, wake up. So there is a risk, which is a sedation risk, but it tends to be less scary than a GA, full GA, and an hour under anesthesia. There's risks of local infection. So in the earlier days when I was doing it, I was a bit cavalier, and I wouldn't even properly clip the knees, but then I did get an infection in one joint. So now I prep for surgery. I prep the knees as if I'm going to go and do surgery, and then I inject them. So that's another risk is potential infection if you're not hygienic. And then there's bleeding. So you can get some bleeding into the joint, and that's painful for the dog at the time. But the ones that's happened to me, it hasn't been many. I've probably had 2 or 3. And I just checked today, I've done 1,162 prolotherapy procedures. That's not dogs or cases, but if you work on roughly 2 to 3 per patient, it's close to 500 cases done now. So I've had a few bleed, which at the time is sore and a bit stressful for you and the owner, but the resultant fibrosis from that is spectacular. So, you know, I'll just explain, okay, this is not great now, but down the line, we're going to be really happy this happened. And I really can't think of any other risks associated with the treatment.
Yeah, I think one of the great things about in the older dogs is that our owners are usually very hesitant to go ahead with surgery. And so this is an option that you can say, because we can always do surgery later, right? So you can always say, like, let's try the prototherapy, see if they respond. If they don't, you know, and then you decide, okay, well, this is not working, then we can go ahead with the operation. And I think for the owners, that really is reassuring for them, especially those ones that are worried about the anesthesia, worried about putting their old dogs through that.
Quite right. That's another light bulb moment that I've learned, is that, you know, cruciate surgery is not an emergency. We don't need to put emotional pressure on the owners to say that if you don't operate now, your dog's going to limp forever and get terrible arthritis. And so we don't really have to do that. We can talk through them and all their fears and address their concerns and start with Prolo, give it a few weeks to a month even, or 2 months, 3 months even, and I can still get a very good result with surgery 3 months down the line. And I do. So those that, because Prolo definitely doesn't work for every dog. And so some still end up in surgery. The only thing is that I have a good heart-to-heart with the owners up front and before we start, and I say, look, if it doesn't work, we've stretched this whole thing out by another 3 months, you know, and the tendency then is, oh, Steve, if only we just operated from the beginning. But, you know, that's hindsight, which doesn't really help us. I like to explain to owners that as vets and as doctors, humans, all the same, we can only make decisions based on what's in front of us on that day or in that moment in time. We have no idea what's coming. So we make the best decision we think at the time, and we stick with that. Sometimes you got the right decision, sometimes you don't. But nobody else can do better than that. And then, and so yes, if I have to do surgery, I found that the prolo I do doesn't impact on the surgery at all.
Yeah, and if they do rehab, it's like prehab, right? So they're strengthening and still carrying on and training muscle. So.
Correct.
Great. So another question, one of the listeners says, I'm a physio from Northern Ireland. My own 14-year-old dog has just ruptured a cruciate this day last week. Reluctant to do surgery and trying to rehab her as best as I can myself. I'll have to see if any local vets have access to prolotherapy over here. And this is one of the things that I love about prototherapy is that, for a lot of the things that we learn as vets, maybe new surgical techniques or regenerative medicine, sometimes, we need to go on a course, but you don't have to go on a course, right, to do prolotherapy. The veterinary skills that we learned at vet school are adequate enough for us to be able to do prolotherapy. I mean, you researched on it, right? And then you said, okay, let me do it.
Exactly. You have to be upfront with the owner. You have to say in the beginning, look, I've never done this before. Here's some videos of them doing it in humans. I'm going to have it a go. I'm not even going to charge you because we're both learning together. So, your dog's a guinea pig kind of thing. And, you have to have a good rapport with the owner. You don't really want them to turn around and stab you in the back down the line. So, luckily, I've got so many owners I've been kind of friends with for many years. And that wasn't really a problem for me to get them on my side and to try. There's no special skills needed. You know your anatomy, and the drugs you use are things you work with all the time. It's really just a confidence thing. It's really just to say, okay, I'm going to try this, and I'm going to stick with it for a while. There are going to be failures in the beginning, especially, and you're going to have some doubts and wonder whether you should carry on. But your skills get better the more you do, and you fine tune it until you get to a level of confidence where you're just happy to tackle it, and can be confident with the owner. There's quite a lot of videos to watch to help you, and every vet or doctor, human doctor that does prolo has a slightly different style. You develop your own style as you do it.
So you've lectured on this topic here in South Africa. Won't you tell us of your experiences, how other vets have taken to the idea of doing prolotherapy? And I know you've got a really great story about a vet who was in the middle of nowhere.
Overall, it's been very heartwarming. I mean, obviously, I've ruffled some feathers because, I'm changing the paradigm shift. And we were taught at university that, you have to operate on knees. And if you don't, the knee's never going to come right. So I'm challenging that. And but overall, it's been extremely heartwarming that the vets that have decided to take it on board and give it a try have mostly been happy with it. They often WhatsApp me or tell me their progress. One I really enjoyed was an email I got from a vet out in the Cape, in the Western Cape, in a tiny little village, and he said, "Oh, Steve, I can't thank you enough. You have changed my life. I used to feel so helpless when these little or big dogs would come in with cruciate rupture, and I'm not a surgeon. I don't really want to do surgery on knees, and I would have very little to offer the owners other than a long journey and an expensive surgery done in a referral center or limping and anti-inflammatories for the rest of its life. And now I've got something I can do, and it's easy, and I don't fear seeing that cruciate coming anymore. I can do something for the owner and the dog." So it was really heartwarming. I get a lot of messages from all over the country and sometimes the world as well, just asking me, a bit of advice and then some feedback. Yeah, I'm happy. It's going well. Or, thank you. Yeah.
It's so interesting because prolotherapy is a procedure that is done more readily in the human field, right? But for some reason, it's not as accepted in the veterinary industry. Do you have any ideas why? I give a long talk to owners when they ask me that question, and it's mostly I don't even know if it's true, but it's how I rationalize it, and it goes something like this. So before the 1950s and before the Swiss developed non-rusting stainless steel implants, and orthopedic surgery wasn't a big thing, knees and ligaments were healed with rest. And prolotherapy was a known thing. So it was started in 1930 by a doctor in America.
And it was very popular to get ligaments to heal from the 1930s right up to the 1960s and 70s. But once the Swiss had pioneered their implants and orthopedic surgery took over, the whole world decided, no, you must fix things with surgery. Damaged joints, ligaments, bones, whatever, that's ortho, go for surgery. And so that's been basically the mindset from the 50s or 60s in veterinary and human, until recently when superbugs arrived on the scene and people started dying post-op from infections. And they're going, whoa, I don't know if I want to have surgery anymore. Is there another way that we can look at maybe getting healed without surgery? And so that's when prolotherapy resurfaced and become quite popular in humans, and now in veterinary as well, because we also have superbugs in animals. And I've had some ops where I just wish I hadn't operated because I've got a terrible bug in the joint. It usually happens not at time of surgery, but post-op licking. And so what's happening is the dogs are living with their superbugs on their skin in harmony with themselves. But if those superbugs get into invade anywhere, you've got no antibiotics to treat them. So I think that's probably why it's coming back, and will continue, I think, to grow in popularity. The fact that there's no sort of specific course to go on and nobody's specifically teaching it, I think, is in academia, they're holding out there. They're not going to teach students because they're not so sure they should teach students to do that. They're still sitting on the fence, I think, and waiting to see how it pans out. So our vets in South Africa at this stage aren't taught anything about it, as far as I'm aware, at Honest to Put. And so they're naturally skeptical of it when they are asked in private practice. They have private practice, and then they got asked by a client, and then this wacko vet in Westville's doing prolo, and they well, I don't know anything about that, because they can't. They're naturally nervous to recommend something they haven't even been taught about. But I think it'll grow. I'm hoping that faculty will ask me to lecture there one day on it.
And I think the fact that you are, collecting, all your stats over time, you can publish something, I think that's often with vets and with the vet schools, they want research and publish articles about it, So I think we're in that stage now where, we obviously just need more people to do it. And so I really want to encourage all the vets that are listening out there, if this is something you're thinking about, Steve, can they reach out to you just to get 100%. Some advice about it, no matter where you guys are in the world? Because this is something that you can do. You can do it. You have the skills to do it. Maybe you just need a bit of support from Steve, and he's happy to give it.
Absolutely. Spread the word, and if I can help a few other dogs around the world heal without having to have surgery, what a pleasure. And I'm a surgeon. I keep saying to myself, why am I doing this? But it's because at this stage in my career, and having lived through so many disasters, I suppose that comes out as if I'm a bad surgeon, but I have had disasters, and there's a sort of desire now my patients have to earn their surgery. They really have to earn it before I'm going to now go to surgery and take a risk of post-op complications, which are severe and which I wish I'd never even gone down that road of surgery. So if I'm really happy to share. People can reach out, steve@westvet.coza, email, and I can reply, and we can get a WhatsApp conversation going. So no problem. I can send them videos I've got quite a few videos of me doing prolo, which they can look at. Yeah.
Awesome. We've got a few more questions, Steve. So somebody asked, what rehab protocols do you recommend after prolotherapy, and is laser an initial contraindication? If not, how soon after procedure?
So what I normally recommend is the patient start rehab a week after the prolo, and they go weekly. And then they miss the week when they're coming for their next prolo. I'm quite vague on how laser actually works. I don't tend to advise it at all. And the physios that I work with don't do laser on my knees. So I battle a bit to answer that second part of the question. I have read a bit about how it's supposed to work, but I just can't get my head around it. So maybe you can help me, Megan. What is the philosophy of the laser?
I'm not sure whether it would be contraindicated. I mean, it does stimulate
Does it
cells.
increase blood flow? Or?
Yeah, it can. Yeah. So I think, yeah.
So that would be beneficial in my mind. So we want to create inflammation. We want to bring blood into that area. We want to stimulate fibroblast activity. We don't want to starve them. We want them to be as happy and as active as possible as fibroblasts. And we want to lay down as much collagen as possible. So if that's the premise of how the laser works, then I would be happy.
Yeah, in my mind, I'm thinking about like shockwave therapy is more similar to prolotherapy. And that's actually what we're doing. So shockwave therapy would be the same action as prolo, really.
Yeah, okay. Where you're causing micro trauma of the tissues and creating inflammation. Okay,
yeah, it'll be interesting. I think we must maybe ask one of our specialists that lecture us about prolotherapy and laser and whether it's contraindicated. I mean, the other contraindications, obviously, for prolo are anti-inflammatories, so we don't want to be giving those.
Yeah, none of my dogs. Yeah, they don't go home on NSAIDs, and they often come to me as referrals already on NSAIDs, so we stop them straight away because we don't want to turn off the inflammation we've created. So they go home on pain meds like Panado and Tramihexal.
Yeah. My gut feeling about laser is no to laser during the prolotherapy period, but I might stand corrected. So we'll ask one of our lecturers that lecture on laser to look into that and to give us some advice about it. All right, another question. After this procedure, is it important to bandage the joint?
No, they don't need a bandage at all. The leg can be a bit bruised. It can be a bit red and bruised for a day or two around the stifle where you've injected. I don't brace them. I don't bandage them at all. The confinement is not as severe or as strict as post-surgery. I want them to walk straight away the next day, leash walking on level surfaces from the next day. They need to start walking. It's part of building their quads, and they'll get more structured exercises from the physio or the rehabilitationist when they get there. They shouldn't run free in the garden or the yard, chasing whatever they chase, monkeys. And here in Westville and Durban, I pay a retainer to all the monkey troops because they keep me in work. So I give them bananas once a week in every area I lay. I'll give them some bananas. Say, thanks, monks. Keep you up the good work, because if it wasn't for you, I would never have as many Cruciates as I do. But yeah, whatever they're chasing, they shouldn't. And they should be confined mostly indoors, no stairs, and then just leash walking.
Okay, great. This is a really great question. So is there a time period after the initial injury that prolotherapy has to take for the best outcome?
Trying to get my head around that. Is there a time period after initial
injury? They're saying, like, if the injury happens now, and then
right.
Later they come to you, is that a
brilliant question? Okay. So my experience would be, if you can get it within a week or two from when it happened, that's great, but it's not essential. I get dogs that have been limping for 6 months while the owners hummed and hawed about what to do until they found me. And I still get good results with those dogs. So they've been trying to heal for 6 months on their own, and then I just encourage them to heal. So, it probably is better to try and get them as soon as possible, because at that stage we've got no muscle atrophy yet, but it's not essential.
Awesome. So, Steve, obviously we've been chatting now more about cranial cruciate ligament ruptures. Have you used prolotherapy in any other conditions and had any success?
Yeah, I have. I've tried it in quite a few different situations. Probably the second area where I've had some nice success is shoulder instability. So shoulder instability can be quite a challenge for the surgeon to try and reconstruct the ligaments, and but the cases are very minimal. I see maybe one every 7 months or one a year. So I've got like 5 cases. So it's not even enough to really write about. But those dogs have improved with Prolo. I've got away without having to do surgery, but they've been little dogs. Yeah, all of them. But they're all dogs under 20 kilos. Yeah, if I had a Great Dane or something like that, I'm not sure I would get enough scar tissue or fibrosis with Prolo to provide stability. Yeah. Then I tried, and it's something I need to go back to. I don't think I tried hard enough. But dogs with extremely lax hips, these young puppies, 7-8 months with severe laxity and in pain, other vets, a lot of them are treating those with prolotherapy and getting good results. And I started, but it didn't seem to make much difference, just one treatment. But I think I gave up too soon. So that's back on my list of treatments for these very, very dogs with very loose hips, terrible x-rays, and in a lot of pain. In the past, I would just take them straight to surgery if I could, if the owner was on board, but financially. But now I know these dogs, their hips tighten anyway when they get to around 13, 14 months. And a lot of the pain goes, and physio is fantastic to just get them through that painful period and get them to 13 or 14 months, and often everything settles down and those dogs are great. And I think I want to get back into that and do Prolo with the rehab on those loose hips, Prolo once a month, and then rehab to get those lax hips to tighten, and try and get them through. Just say to the owners, listen, we're just going to have a bit of a hard time now from 7 months to 13 months, but let's just try it because it's worth it. Because if we can get them settled and they have their hips from 13 months with no problem, what a pleasure. And we haven't had to do femur head and necks or total hips or anything like that.
I found that those cases really respond well to acupuncture. So together with the rehab. So maybe, prolotherapy initially, and then acupuncture for the pain management. Because, I've had cases that have been on, anti-inflammatories and painkillers, and literally 2 weeks after acupuncture, we've taken them off completely. And that's rehab. Yeah. So they respond really well. So somebody said, and unfortunately, Facebook is not telling me who it is, but they're saying, Steve, can I fly you over here, please? So not sure where they are.
Depends if it's in Mongolia, maybe not. But if it's in the Canary Islands, yes. No problem. Some of the other things I've used it for, so hyperextension injuries in our dogs where you're thinking, oh God, this is going to be a carpal arthrodesis. I absolutely hate carpal arthrodesis because they just are never a completely normal limb again. They've restricted motion and restricted a different gait and an adapted gait. So I'll do my level best to rehab a carpus before surgery, and I'll wait as long as 12 weeks before going to arthrodese that carpus, and I will combine a prolotherapy into the flexor tendons and the suspensory ligaments of the carpus and physio. And I did a German Shepherd bilateral, fell from a height, severe carpal hyperflexion last year. It's not perfect. The owner sent me videos the other day. He can still see he hyperextends a bit, but he's super functional, not in pain, happy dog, no surgery needed. And there's nobody else that looked at that dog in my practice or the referring vet that said you'll ever get that dog right without surgery. Yeah. So it's something definitely to try before arthrodesing the carpus. And then any kind of collateral ligament injury is a good candidate for prolotherapy. So carpal, radial or tibiotarsal luxations and partial luxations where they're not badly displaced, definitely no surgery needed there, just prolotherapy. Yeah.
Let's be honest that carpal arthrodesis is not perfect either, right?
No, you get complications. And, you get implant failure, and I don't like them. So if I can avoid them, I will.
Going back to the cruciates, is there any cases where you would not suggest prototherapy?
In the cruciates?
Yeah, so let's say
one big thing we haven't touched on here is meniscal tears, concurrent meniscal tears. That's a big complication if there's a meniscal tear. And it's quite hard to know if there's a meniscal tear sometimes. Sometimes the dog comes in, the knee is very swollen, marked effusion. It's not even trying to weight bear 2 weeks post cruciate rupture. You flex that knee and there's a click, there's a definite click. And you kind of say, okay, this is a meniscal tear. We're not going to get this right with prolotherapy. We're going to have to do surgery. Sometimes it's more subtle, and you have to go on clinical signs in response to treatment. MRIs, I give the talk to the owners. We can do an MRI to see if there's a meniscal tear. So that's 12 grand, and we've only ruled it in or out. We haven't even treated it, and then I'm still going to do surgery. So it doesn't make sense to me. Scoping is a mission in the knee. I scope elbows, I scope shoulders. I just haven't got into knee scoping because arthrotomies are so easy and quick and don't seem to have any deleterious effect on the knee. So basically, if if I'm like 90% sure there's a meniscal tear based on clinical signs, I won't be talking much about prolotherapy to the owner. I'll be saying, I think we've got to go straight to surgery. If I have some doubt, I'll warn them, and we'll go on clinical response. And if we get to 8 weeks, and I take videos each time I see the animal, and we'll look at the videos together. And I also have learned now to get videos from home, because the dogs often walk better at the practice than they do at home, because they're on adrenaline and they're nervous and they wait there better. So it can be a bit fooling. You think you're doing a great job, but at home they're not so good. So I get the owners to send me videos from home, just the normal function of the dog and what I'm seeing, and we look at them. And if we're really getting a poor improvement at 8 weeks, I'm starting to say, no, meniscal tear, we got to go look in that knee. So that's the contraindication in Cruciates, as if there's a concurrent meniscal tear.
Yeah. And how often do you have?
You can still, sorry to interrupt, you can still do the Prolo. Sometimes you get lucky and they grind it away and it goes, the pain goes and they come right. But generally they need help, surgical help.
What percentage of cases would you say you do the prolotherapy on and then still end up having to operate?
Okay, that's good stats. I've got them on my computer here. So I did a owner survey. We sent out at 210 people. We sent an email, a questionnaire. We only got 70 responses, but of those 70, we got the following. So out of 72 cases, 62%, 44 made a full recovery in the owner's eyes. Very happy. Dog not limping at all under any condition, excessive exercise, nothing, full recovery. 26% markedly improved, happy dogs, but if they go for a long run or a long walk, they can be sore that night and the next day and limp a bit on rising, but settles quickly. Within a day or two, they're fine again. So that's 26%. 4% failed, and then 8% improved really well, overdid it, tore a meniscus, and ended up in surgery. Okay, so 10% basically out of that, and that was all size dogs. 10% ended up going to surgery after starting Prolo. So it's quite good odds that Prolo is going to work. So only 10% went to surgery after I started, and the odds are better the smaller the dog. The smaller the dog, the less likely they have meniscal tears. And my success rate in small dogs under 20 kilos, I just looked at my stats. So 87 dogs treated with Prolo for cruciate rupture, 2 ended up in surgery.
Wow.
The rest healed nicely, yeah.
Great.
So I can be quite confident and optimistic for my owners with the little dogs, the under 20 kilos. I can almost give them like a 90% success rate. Then from 20 to 40 kilos, I'm giving them like a 65% success rate. And then for the really giant breed dogs, I'm giving them like a 40% success rate with Prolo.
Okay. Out of interest, do you give them success rates when you do, if you mention you're going to do an extra capsular repair?
Yeah, absolutely. So I did a survey on my X-caps way back in 2010 when I was still doing a lot. And so I've been doing X-cap repairs from 1995 to 2010. That's 15 years. And the results are almost identical to prolotherapy. So roughly 65 to 70% full return to function, 20% much better, not perfect if they do a lot of exercise, but happy owners, happy dogs, and then 10% failed and either had to be redone or limped for the rest of their life. So what's really nice about Prolo as well is if you do an X-cap surgery and it fails quickly, so if your implant comes loose at 4 to 8 weeks and your heart sinks and the knee's totally, you don't have to reoperate. You just have to do Prolo on your failed implant, and you can rehabilitate that knee without a repeat surgery. And I've just had one like that. Not my surgery, but because I very seldom do X-cap surgeries anymore. For the big dogs, I do TTA rapids. But for the little dogs, if most of them come right with Prolo, so I hardly ever do X-cap surgeries anymore. But if you do have a failure, then Prolo can rescue you before you have to do surgery again. How does X-cap surgery work? Okay, because everybody frets about how tight must I make my ligament, my new ligament. Oh, it's come loose. I can feel movement in the knee at 4 weeks. I can feel movement at 8 weeks. Well, that's normal. There's hardly anybody who's going to put a X-cap suture in that's not going to loosen. But basically, at the bottom line, at the end of the day, what you achieve with X-cap surgery is fibrosis, which is the same as prolotherapy. Yeah. And it's just a race in time between developing fibrosis enough to provide enough stability to the knee when weight bearing, it's a race in time between implant failure and fibrosis formation. So most implants fail around 8 to 10, 12 weeks, but that's the time you've got some nice fibrosis going. And that's why the X-cap surgeries work.
Great. Are there any other stats you want to share with us?
Yeah, I think we touched on most of them. The 15% of the normal, so-called normal knees after Prolo have gone into rupture, not 54%. The little dog success rate is phenomenal. The bigger dogs, not so much. The difference between X-cap surgery and Prolo in my hands on the stats and the survey is very, very almost identical. Yeah, I think that's about it.
So we got an answer where they want you to be flown to. It's Northern Ireland.
Oh, I love Ireland. I played golf in Northern Ireland 2 years ago. It was magnificent. I remember the Guinness, not so much the golf. It was fantastic.
I actually went to the Guinness factory in Dublin. Yeah, you must go there. Have you been there?
Not the factory, but I've been to Dublin.
They've got this like amazing pub right at the top with these beautiful views. I went there for a feline veterinary conference to Dublin, and part of the entertainment is they took us to the Guinness factory. So
no, if you pay my flight and you can get me past South African COVID strain, I'm allowed into Northern Ireland, I'll be there in a shot.
You might have to ship Steve a vaccine over, because we're not getting vaccinated anytime soon at the rate that we're going. I think we're on 800,000 out of our 55 million.
Yeah, exactly.
Awesome, Steve. Thank you so much for your time. It's been wonderful chatting to you. And I love your passion and energy. And one of the things I absolutely love is, as a veterinary surgeon, that you're so passionate also about rehab, and we really appreciate that. And it's great that you.
I don't know how it's almost criminal that I operated from 1989 or 90 to 2000 and somewhere like 5 without any rehab. It's like, what was I doing?
We love hearing that. We love it. So we wish more people would hear what you just said. I think we'll have to take a little snippet of that and post it all around on YouTube and Facebook. Thanks so much for your time, and thanks to all of you guys that have joined us live. If you're watching it as a recording, you can still post questions. If you've got any questions, I will reach out to Steve and get him to answer them. Thanks, guys. Have a wonderful rest of the day. Thanks, Steve. Bye.
Bye.